Good morning, everyone. Welcome to this new Tuesday Connect session, the second in April. So after the JAMRAI dashboard, it's another interesting subject. I will tell the floor to the coordination team of Work Package 6, so task 6.1, on this subject, so international surveys on antimicrobial stewardship programs. So let's begin, and you can share your screen if you want.
My name is Maria, and I'm really happy to be here with you today to share the results on the international surveys on AMS programs on behalf of 6.1 coordination team. As you all know, this is a journey, and our final step, our final goal is to develop the 3 common EU frameworks for AMS, including core elements and core competencies for the 3 settings: hospitals, primary care, and long-term care facilities. But today I'm going to focus on the results. I will present the results of the surveys on AMS programs from these 3 settings. Our aim was to map and collate the core elements and core competencies of AMS reported not only in national action plans, but also on equivalent national strategies or programs regarding these 3 settings: hospitals, primary care, and long-term care facilities for the elderly. We conducted 3 international surveys. We invited to participate 27 member states, together with Iceland, Norway, and Ukraine. We wanted to assess the current status of AMS programs in the 3 settings in 2025. We made a preliminary work together with SCAP and other stakeholders, and through the liaisons, we contacted national representatives in order to ensure that we got a coordinated response from each country. After sending several reminders, we achieved a very high response rate. So we would like to thank you all for your commitment and your contribution. We're going to start with the key findings from the hospital survey. What did we find? We found that there is a strong inclusion of AMS in national policies, but there is limited reporting on implementation and accreditation. Most participants, 79.3% of the participating countries, reporting having NAPs or equivalent programs or strategies, which included hospital AMS core elements, but only 27.6 reported elements related to implementation, and only 10.3 related to accreditation or certification. If we look more closely, we can see that there is a variation across the different sections. Governance is generally well established. There is a strong institutional commitment to AMS, together with a strong AMS and IPC collaboration. Structures are reported at moderate levels, but coordination across healthcare settings is less frequently reported. There are also variable levels of resource reporting. Prescribing monitoring tools and dedicated staff AMS staff time are reported in around half of the participants, while recommendations for access to 24/7 AMS expert consultation are very limited. Financial resources are moderately included, and IT tools remain limited, with both access to patient data and more advanced tools, such as computerized decision support tools, are reported at lower levels. Regarding interventions, there was a general moderate reporting with variation across different elements. Some core interventions, such as AMR awareness and AMS communication, timely diagnostic results, and locally adapted guidelines, were highly reported. However, postscript activities related to audit and feedback were less frequently reported. There we found a moderate reporting of education and training activities, more specific activities such as prescribing activities and also on regular AMS training. There was a moderate to low reporting of competency-related elements, a set of professional competencies for healthcare professionals in hospital ASP. It was reported in around half of the NAPs. Monitoring is widely reported, but it was not consistently detailed. Indicators and their reporting are commonly included in national strategies. However, recommendations for AMS quality standards are less frequently reported. Now we're going to move to the long-term care facilities for the elderly setting. And when we move to this setting, we find there is more variability than in hospitals. Now, this setting received limited attention, but now there is increasing attention, and there are several ongoing strategies trying to identify priorities and actions on this setting. What we found is that policy elements are partially reported in national strategies, and core AMS structures in this setting are less consistently reported. Higher reporting was observed in governance and organizational structure, and lower reporting was found in AMS programs. As we expected, we have found lots of variation across organization, financial, and workforce models. And the predominant ownership model is the public ownership, followed by for-profit private organization. Oversight mainly relies on regional and local authorities, followed by ministries of health. Long-term care facilities are mainly supported by primary care centers, and financing is mainly mixed. Physicians are mainly employed through mixed models, where nurses are directly employed by the long-term care facilities for the elderly. Mixed models, the mixed model in which physicians are mainly employed means that some residents receive care from their own general practitioners, but some others receive this care from dedicated physicians or from physicians who are directly employed by the long-term care facilities. Monitoring is generally reported, but it's not consistently detailed. Definition of indicators or monitoring frequency were less included. This may be partly explained because medication access comes from multiple sources, so it's really difficult to track prescribing and consumption. AMS program structures and components were also underreported. We found higher reporting of supporting AMS documents than implementation programs. We found gaps in reporting of AMS team structures and competencies, and lower reporting of evaluation guidelines. Having a look at the perceived importance of the barriers to AMS implementation in this setting, barriers related to resources and availability of data are perceived as the most important for AMS implementation in long-term care facilities, as reported by the respondents. Resources barriers include workload and staffing and high turnover of staff, but we know that barriers related to challenges related to human resources go beyond these barriers because also training and behavioral aspects are important to take into account. And availability of data is also important to guide interventions and monitoring in AMS. It's also interesting that we found that there are many services which are already in place in long-term care facilities. However, they are not reflected at policy level. We have to note that, that implementation was not always universal because several countries reported that the availability of this service was limited to only to some residents. And now we move on to the primary care setting. We found that just over half of the countries reported that their national strategies include primary care core AMS elements, with a higher reporting in national reference guidelines for common infections and reference indicators, and lower reporting of financial support, professional competencies for the healthcare professionals. Having a look at the sections, we can see there is variation in reporting across AMS components. There is a higher reporting in monitoring and education, moderate levels of reporting in human and technical resources, and lower reporting in governance, interventions, and implementation of evaluation and certification or accreditation systems. Starting with governance, it was only partially reported in national strategies with some variability across components. We found higher reporting in budgeted support, dedicated AMS teams and formal commitment, moderate reporting in multidisciplinary structures, and dedicated time to facilitate leadership, engagement, and accountability. However, a lower reporting was found in manager involvement and structured local ASP framework. Technical resources are more frequently reported than human resources. There is a higher reporting in tools to monitor prescribing quantity, updated AMS guidance, and importance of access to electronic medical records. Moderate reporting in tools to monitor prescribing quality, and lower reporting in e-prescribing support tools, in more advanced tools. Regarding human resources, we saw a low reporting in core AMS team composition, roles, and leadership. And also, a core team composition is not consistently specified. When it is included in the NAPs, it's not specified. The countries that reported having this AMS team composition in their NAPs or similar or equivalent programs or strategies most commonly include physicians and pharmacists. There is a strong reporting on diagnostic access, but limited reporting on clinical and microbiological data. We found higher reporting in timely access to diagnostic results, mostly to microbiological results, but a lower reporting in access to integrated clinical information and susceptibility data. Interventions are variably reported. Interventions related to audit activities are moderately reported in audits of high impact antibiotics, but there is a lower reporting in audit of specific conditions, including mostly ITU and pneumonia. Coordination activities, regarding coordination activities, we found a higher reporting in coordination between hospital and primary care, but a moderate reporting in coordination with IPC teams and provision of local resistant data, and lower reporting in coordination with community pharmacies. There is strong reporting on education and training activities, but limited reporting on competitive frameworks. We found higher reporting in prescribing training, general education, AMR awareness and communication, moderate reporting of peer-to-peer consultancies, and lower reporting in competency frameworks with limited definition and specification. We found a harmonized reporting across indicators, with higher reporting in antimicrobial consumption indicators, but lower reporting in clinical and process indicator, and documentation of prescribing indication was also moderately reported. There is limited reporting on implementation guidance and minimum quality standards. We found limited reporting of assessment procedures for implementation, and also reporting was limited, reporting of accreditation or certification systems, and it was mostly restricted to primary care facilities rather than prescriber or AMS teams. Now, after analyzing the surveys, we have asked permission to each country to publish the data in a pseudonymized and aggregated way. We have in the following weeks or days, we will share this pseudonymized and aggregated survey report with all the respondents to allow them to validate the previous responses. And finally, once we gather all this feedback from the respondents, we will publish the 3 final reports with pseudonymized and aggregated data. We must acknowledge that we have not conducted an external validation from the data. These are self-reported data based on national strategies, and it will be a country-level validation, but not an external or independent validation. And now, as you know, our final step, our goal is by April 2027 is to develop these the 3 EU frameworks, including the core elements and core competencies on AMS for the 3 settings. And what comes next are the online meetings, the online follow-up meetings. And our aim is to bring together all the information from the international surveys and from the 3 workshops, and combine it with the information that we gather from the evidence synthesis, which is being conducted in parallel, to fit all this into the 3 frameworks. And that's all. Thank you very much for your attention. Have you got any question or?
Yeah, thank you. Thank you very much. It was really, really clear. It's good to see these results. And indeed, yes, if you want to intervene, if you have a question, you can raise your hand, and or you can write on a chat. So
I have one question. So I understand, obviously, the need to aggregate the data to be able to publish the report. But do you also plan to give more targeted feedback to the different countries and maybe also inform upcoming mentorship and observership with some data from those surveys?
Hi everyone. It's Maria. We have the names changed. So yes, we plan to give it to feedback. I mean, I think the countries need to know what the data is there and what that they're providing. So that's why the pseudo-anonymized data. So they can either like see what the documents are, where they collect information, how to improve, which areas are also like different from other countries reported. So if they need to work on something else, so that will be very important. As well as JAMRAI, I think even if we have aggregated data as a consortium, we need to know which is out there and how to map it in Europe. So that's for sure. And also, these results have been very good to inform about the observership and the mentorship, as you say, because we have now like straightforward targets that we want to address, and we have information that we need to go deeper and read more and analyze more, and some information that we know is already very well established and people knows and how to access. So maybe we need to go for the parts. So we keeping in mind that we wanted synergy and implementation. That's like our core words from the very beginning of the this work package. So we have to go to those targets, and that's why it was very important to map and collate what it was already there, existing there. So what are the policies and the frameworks? We also know that it's like a short screen. So if some of them are updating, so maybe the next year we have different information, but this is what is going on now.
Thank you.
Thank you, Johan. I think
Thank
more
you.
questions. Lucy, I think you were
Yes,
first.
Lucy.
Thank you very much for the presentation. I actually had a question similar to the one of Johan. As for other studies, like for the AMR dashboard and like other outputs on other work packages, some data were published at the country level. And so I was wondering if with the approval of each country, you could not plan to publish the data at country level. And if a country refuses, then you hide the information from that country specifically. But I think it would be really interesting for the readers to know what's going on in Europe per country, as the landscape is really, really heterogeneous, and you might have similar situation more in neighboring country, for example. And yeah, I think having the data per country would be really interesting.
We completely agree with you, because we can map regions, you can see areas, you can see, I think it's very useful for everyone, your own country and for everyone's country. But we receive like explicit said that some countries did not want to that. So at the very beginning, we agree that it was going to be aggregated and pseudo-anonymized. But we hope that now that they can see the reports, how the data will be expressed, I think that some of them will agree. So if we have full agreement, yes. Otherwise, it will be very weird to have one or two countries not there. So it won't be fair with the initial address. So we will ask for it. If we have full consent for all of them and we can ensure that all the data for Europe is like consistent, then we'll give it. Otherwise, it had to be aggregated for the publication, but not for the internal JAMRAI reports, for the information. As Johan says, it's very important to have that information.
But if you miss one or two countries,
it will be quite obvious in the map.
Yeah, okay.
We can discuss internally and say, but it will be quite obvious to have one or two gaps.
Okay, thank you.
To move the data, but we are in those conversations. Yeah.
And yes, Anna, and after we have a question in the chat. Anna, please.
Yes, so can you hear me? Can you confirm that you can hear me? Yeah, okay, super.
Yes.
So good morning, everyone. My name is Ana Paula Coutinho Reis. I work for the W2 Regional Office, and I have the WHO Region Office for Europe. I believe that my colleague Ketevan Kandelaki was interacting with you, Maria and Maria, right? And Marias. So I guess that perhaps some of my comments she already mentioned to you. So apologies for the repetition in advance, right? So I was wondering, it said for the publication as baseline information, if you're going to use the TRACS data, because TRACS also has similar TRACS, for those who are unfamiliar, is the tracking progress on implementation of AMR national action plans. So includes several questions on human health, animal health, environmental health, and I think agriculture also is the quadripartite. So then this is one thing about the using this as a baseline numbers for the countries. I understand that some countries will not, are not willing to have their data, published, and it's fine. I think this is, but I think for the European region, we are quite proud to say that we have a very high coverage. I think all countries have been reporting to TRACS already for more than 5 years. So you have a good baseline, even if you want to, call it a trend. And then to connect with that, so I was wondering if you are also considering to put as a final destination the EU targets, right? Because the EU, I think it's called resolution on the combating antimicrobial resistance, also defines the targets for adoption of the AWARE classification. And I guess that perhaps that could be also something to show how far we are or how close we are from the target. And perhaps if it's time permits, if you consider sharing this feedback to those countries participating also in the survey, because this can also perhaps drive a little bit of policy and make some changes while we are still, preparing the publication. Maybe it's not useful for the publication itself, but still useful for overall antimicrobial stewardship efforts at country level. Thanks.
Thank you.
Thank you so much, Ana Paula. Completely agree with everything you say. I mean, we need to provide useful deliverables, something that we can actually we use here in the hospital or whatever, no? So when we started to plan the content of the surveys, the first thing we did was check all the things that they were already published, like all your track publication initiative also work together, for sure with WHO, but also like ECDC, SMIC, other countries, other societies, to see what are we really looking forward, because at the end, the final goal is not to have the publication, is to have a common framework, to have a list of competencies, core elements, something that we call apply, use, or use for certification system, or to have a minimum standard to follow all across Europe. So exactly that. So the target is to have something useful. The content in this survey, as my colleague Maria pointed out, is what are the countries saying that they are reporting, they are recommending. So it's not everything that is out there. So we will be with other information from the workshop that we put together, almost 200 people from different backgrounds, different countries, different origins, also for human environmental, were invited for implementation challenges, with evidence synthesis of all these initiatives already in place. So we put all of them together, then we will do comparatives. So we'll have more data, more information on that. So I don't know if I answered the question, I left something, but for sure, we try.
Yes, so Elena, if you don't mind, if I can just have a quick. So yes, you did answer, and I just want to add one thing I forgot to mention is thank you very much for addressing my questions. Is just to inform everyone. So I think 3 weeks ago, WHO headquarters convened a meeting with all the regions and WHO collaborating centers and the usual suspects in the AMR arena to start discussing about a proper course on antimicrobial resistance, not and this is the big umbrella, but also including something more more specific about antimicrobial stewardship. Of course, this is just the beginning. This initiative is being, I think, hosted and cared in the WHO Academy, which I think it's really where is the direction that we in WHO we have a great preference, because it's really on addressing or identifying what are the required skills, soft and hard skills that are needed to achieve those competencies. I will try to get more information, what is they are planning to put in the public domain in terms of outcomes of this meeting. And I will make sure that I share with my colleagues from the EU-JAMRAI, so you all have access to that. So I did not attend the meeting myself, but we had colleagues from the regional office that attended, and I know a lot about what was discussed during the meeting, but I'm not sure what is the level of detail that is going to be shared in the public domain. But stay tuned, things are moving. They sound a bit slow, but they're moving steadily and solidly, step by step. Thank you.
It's very good initiative, and we're very happy to share and to be aligned and help with anything that we can. Sure.
Thank you. Elena, if you want to intervene.
So I was looking into the results of the survey, and thank you very much for the presentation. It's very interesting. We work in the work package 8.1 specifically, and we're looking at the capacity building. So I understand that you looked into the self-assessment data that countries report differently. It also is important to understand who are the respondents, but there are so many barriers sometimes at the level of the countries that are better to be assessed by regulatory limitations or policy limitations. And to be honest, also, I'm just coming from a meeting within our work package, and we've been talking about the community surveillance of AMR. And that is something that we pretty much have now data and information about the expectations at the primary care levels of what to do to improve the surveillance other than the blood and the spinal liquid. But in real life, this is not happening. So in all the plans, it is encouraged. There is the dashboard that is also available within JAMRAI that is saying that there are countries that are trying and having that in the policy, but in practice, there is a very different situation. So I'm wondering, because this data will be published, but JAMRAI 2 is all about the implementation. Where we are with this data, and maybe also looking into more the policy limitations, the regulatory limitations, to actually kind of like just try to do a triangulation of all this data and understand what actually the countries would need, maybe also in terms of the capacity building that we work. So I don't know if you have some reflections about that. It was probably a clarification from my side about the self-assessment, but maybe you looked into this and you can share with us some ideas. Maybe there is a different dimension also within JAMRAI that looks into the governance in a different way. Thank you.
Thank you very much, Elena. No, that's one of the main reasons we wanted to have parallel activities, not just collecting information passively through the surveys. That's why we hosted the 3 workshops. There were one for each setting, different countries, one in Spain, Athens, and Slovenia, to gather people there, to gather all the stakeholders, from policymaker to general practitioner, also representative from patients, so everyone there, and say their concerns. And it was focused on implementation challenges. So trying to find out either potential solutions or cases of success in different countries that we could use as an example for best practices, but also what are the common challenges. So if there was something addressed as something that we all find that is a limitation, it should be addressed. So we could focus on those priorities. So those workshops, they were always a first part with different presentation from key stakeholders, and do both, to present what are the policies, what are the recommendations, and what are like cases of success. But then we also have open table discussions, and then the next day we put everything in common to talk and to share experience. So what's going on in Slovenia, what's going on in Spain. So we had a limitation. We were talking national at a national level. So we know this AMS is always like a local level or different degrees of implementation. There's another challenge, but it's still like to have an open discussion, and those information is also recorded, and we have to put it together with the surveys and what is published. But we wanted to have it for first hand, like what's your problem in your setting, in your country, and what have you done to fix it? So what do you identify as a best practice, and what do you identify as a key challenge for each setting? So, and the results were very interesting. And for sure, with other work packages, for sure with other initiatives, for sure with other activities already, other projects already done, or current projects within Europe.
I think it's okay. Just a reminder, so thank you again for today. And our next Tuesday Connect session will be next month on May, with not only one presentation but two, with Richard and Anna Margaret. So we will meet there online in May, and I think that's it for today. Thank you again, everyone, and see you soon. Have a nice day, and goodbye.
Bye. Thank you
Thank
very
you
much.
very much. Bye-bye.
Bye. Bye. Bye.
Thank you. Bye.
Bye.